Hi everyone, my name is Luca. I had the pleasure of meeting some of you in these days, and first of all I want to thank you because I had the opportunity to be here to speak with you and to be on the last day. So in the last few days I had the opportunity to see a lot of themes that actually I thought that were, when I explain these themes to doctors, they always think that this is something new and they don't know what I'm talking about. And actually thank you. Can you hear me now? Okay. And actually, I understood that you are really ready on this topic. So I hope I can give you some new piece of information. So first of all, I'm here to speak about chronic diseases because, as I told some of you, it's my first time with MPN, and it's so good that you have such an active network. Chronic disease is something that, a disorder that persists for a long period of time, more than 6 months for the definition, and the symptoms of this disease impede for a person to have a normal functioning, work, social life, well-being, general well-being. And the fact is that, can I ask up there, this is the old presentation, can you get the new one I gave you on the first day? I'll go on in the meanwhile. These diseases have an effect on, apart from the medical side, on the life of the patient, and they change a lot of things in the everyday life because they have an effect on the role you have in your life. You may have to change your job, or you may have to drop your hobbies, or anything you're doing in your life, and you have to change objective and priorities because now you have something that you have to control, something that has to be in your mind constantly. And finally, it changes the self-perception you have of yourself, because after one 15-minute speech, as in some example happened, with your doctor, suddenly you are a patient, and you are a cancer patient. And it's something that, as we had the opportunity to hear a few minutes ago, is something that completely changes and stops the brain of the patient, because it's a shocking news. And that brings to what is called biographical disruption, and this kind of disruption changes the way you were in your past, from the way you live your present, and the way you will be in your future. Bear in mind that this is not for everybody. Everybody cope with this in a different way, but you cannot ignore the change that are coming. With a disease, with any chronic disease, comes new obstacles. They may be functional, social, or health-related, and so you may have issues moving around or doing your chores at home, or maybe you need somebody to help you doing your work or your activities. And in some cases, it also has social implications, like a few days ago, maybe yesterday or the day before, came the expression to come out of the closet as a patient, because a lot of you told that they did not disclose the fact that they were patient, that they have MPN to their boss or colleagues. And that's something that, as a burden in your mind, you have to bring that with you every day at work, every day you have an interaction with somebody. And in some cases, you may get to isolation, and it can change the way you have a social life, because sometimes maybe you don't want to disclose with some friends, so you stop seeing them, and you just reduce the number of social people you stay in touch with. And then there are obviously health-related issues that impose limitation, a busy schedule, new risk that you have to pay attention. You have to be on watch and wait to see if the symptoms goes over a certain level. And so, yeah, I also had this, which were really nice at the moment. The key element is resilience. It's a common term, maybe you have heard it before, and it comes from biology, and it expresses the capacity of an ecosystem to respond to perturbation or disturbance by resisting damage and recovering. In psychology, we got this term as to the ability to recover quickly from depression, illness, or misfortune. And I had the example that Robert explained, that he didn't change anything. He went on with his life, and because he wanted to go on and not stop after the diagnosis. And that's an example of resilience. It doesn't mean that he doesn't know that he has a diagnosis on his back, but still he decided that he wants to go on and do things with his life. And so this is really, really important. Because after the diagnosis, it's important to build a new normality, because the old one sometimes may not be continued as well. And so you have to tweak your life. And so you have to understand what happened to you, what's your diagnosis, the treatment that you have to take, how to implement them in your life. And sometimes it may be helpful to ask, if they're not provided spontaneously, tools to support everyday life and self-management. This could be just, I don't know, apps, they're really good, or pamphlets that help you have a schedule and where you can put your appointment and to prepare questions to pose to your doctor when you're going to see him. Because in the end, you have to be able to answer these 3 questions. What is my health issue? Yeah, I know it has a long name, it's a complicated name, it changes every once in a while, but what's wrong with me? And then, what should I do to keep in check my health status? And why is it important for me to do it? What's going to happen if I don't take my medication? And I presented this, I made a similar intervention with elder patients who were discharged by hospital, and they have a really high rate of readmission to hospitals. They got discharged because they're stable, they're cured, they have their prescription, they go home, and in 2 weeks they're back to the emergency room because they don't take them, because they don't stop their habits and they don't want to take medication. The fact, let's just say the most critical impact that the disease has, from my perspective, obviously, is the psychological one, because it cannot be, with any diagnosis, you have acute negative emotions that can be sadness, anxiety, fear, terror in some case, and they can go on and proliferate and become real clinical symptoms or syndromes. But the thing that I'm going to tell you that maybe it's not so, it's not a common knowledge, is that those symptoms are functional at the first stage of the disease. Because if you think what they do to you when you're depressed, you just stay home. And from a biological perspective, because in the end we're all animals, and like animals, our emotion drive our behavior. And when you're depressed, you stay home because that decreases the risk of getting infection, of getting hurt going around. And anxiety gets you prepared for what's going to happen, because if you know that something is there, you're on alert. You're always ready to do something. Obviously, they're not pleasant. Otherwise, my work wouldn't be useful. But the fact is that with a chronic disease, they may overlap the specific symptoms like fatigue, headaches, dizziness, confusion, and they can amplify these symptoms if they're not in check. The issue comes when, after the initial phase, those emotions don't stop. If after 3 months, 6 months, 1 year after the diagnosis and the new normality, as we called before, there's still an obstacle in everyday life. If your depression doesn't make you go to work, even if you could for your condition, or you don't want to see anyone because you're sad and you want to go out, or you have fear that something may happen to you, then you're losing pieces of your life that doesn't depend from the disease itself. It's something that builds up. So it's important to know, be in check, apart from symptoms, but also for your emotional status. And with emotional regulation, it's a term that expresses the whole experiencing, processing, and modulating, I wrote here, of emotion. Because everybody has to do that, patient or not. I mean, everybody is a patient eventually. But in everyday life, this is something that can be critical. And you can build up these pathological emotional regulation strategies like alexithymia, so you don't perceive your emotion anymore. Because they're too much, such a burden for you that you don't feel them anymore. Or repression, in which you have those emotions so bottled up that you don't understand that you're actually acting them. Or emotional control, so you say consciously, I don't want to be sad, I don't want to be anxious, but the only thing that you do is that you keep suffering without telling anybody. And you can get up to psychological symptoms and syndromes like from a clinical perspective. It may happen. So, what to do, how to cope with emotional distress? Well, it's important to keep the healthy part of your life that you had before. So you have to maintain social, you should try to maintain social and professional functioning, not to have everything centered on your disease. To acknowledge and express your emotion. It's okay to be sad, it's okay to be afraid, it's okay to seek support from others. Keep the things in your life that get you satisfied. that you like. If you have a habit, a hobby, and you like it, go on and do it, if it doesn't have a contradiction with your diagnosis. Seek for emotional and practical supports by caregiver and professionals. A lot of you spoke about the psychological impact of the diagnosis, and I know because, I mean, in my country, there are really few places, few hospitals that give psychological support after the diagnosis. And that's something that's really critical for us. And after I heard what you said for the last 2 days, I know that it's critical for you as well. So if you're not provided with one, seek one. There's no reason to be ashamed. There's no reason to be afraid of going to somebody and telling that you need help. And the part in which you are really strong is knowledge and active participation. Get patients to have the hand on their condition, to control and to be able to discern what's going on with their life. Because the way you act on emotions have an impact on the adjustment of the disease in your life. It can either go up, in which if you have an active management, your condition improves. If active patients and empowered patients have lesser symptoms in terms of intensity and lesser obstacles coping in their life. While on the other hand, if you develop clinical symptoms, like you have a really clinical emotional distress, that's a risk factor that gets you your disease to get worse. So, and you may develop those two perceptions, those two experiences, those two feelings that are really critical, that are helplessness and hopelessness. And that's what depression patients may develop in the later stage. So it comes to empowerment. A lot of you spoke about empowerment, and it's a really hot topic in this period, but as I told you, clinicians not always have the right perception of what it means. So empowerment is a process that helps patients have control over what they think is important in their life. So it gives them control over their condition. It helps them to self-manage their everyday life, their prescription, their visiting, and improves their quality of life. Because as I said before, an empowered patient feels less symptoms and manages to better cope with them and suffer less from them. So this is not empowerment. Asking patients to make the decision, to make the calls, is what sometimes clinicals believe it's empowering, but that's not. And on the other hand, clinicians may think that empowerments mean that if a patient knows what I'm doing, he'll always agree with me. He'll always be on the same page. So if I say something, he'll do it. He'll take his medication, he'll do what I say, and I won't have any problem. But actually, to be an empowered patient, it means to have a critical way of thinking to your disease. So it means that in some cases you have knowledge and you may not agree with your doctor. You may have to go to search for a second opinion. Why not? Or get to Dr. Google if you know where to look for. So a lot of elements are linked to being an empowered patient. You have to be engaged, for sure. You have to be informed, and that's why the work of advocacy is so important. You have to get collaborative, because it may happen, and in some cases, patients don't want to cooperate because they decide that their fate stays in the hands of the doctor. And if that's an aware decision, you have to understand it before saying that it's wrong. You have to be committed, because your life depends on it, sure. And the last part, and the hardest part on the bottom of this scheme, is the tolerance for uncertainty. No doctor can give you certainty for any kind of disease, I guess. They can give you a reasonable amount of probability, maybe. They can tell you that maybe nothing will just stay here and get this prescription and nothing will happen. But they don't know. So for the patient, it's hard to cope with something that they can handle because they don't know what's going to be. This gets us to the relationship between the patient and the healthcare professional. There was actually an important psychologist, ethologist, which was Bowlby, who developed the attachment theory. I guess it's something new for you, and describes the relationship that children have with their parents in the moments of distress. And they seek their parents to have relief. And it's something that's universal from animals, small humans, and adults, because also adults do this. They change the way they do it. And it has those 4 components. When you're in an attachment relationship, you give the control of the situation to somebody else because you feel that you can handle it on yourself. This figure has to be vigilant of you. He's checking. In order to trust somebody, you have to see that he's looking at you, he's seeing what your distress is in this moment. It's an asymmetrical relationship, like the one you described with doctors, in which somebody is on the top and the sides, and you're on the bottom. And finally, it's proximity. With that intervention with elderly people, I heard a story of a patient who called his doctor twice every hour for the first week after discharge. Because you have to know that he's there. But good news is that humans are a bit more complicated than that. And we have several what are called interpersonal motivational systems, so different kind of relationship. And every one of these have a different scope, a different objective. And you can see we have the sexual that define the couples, the mating, and finding people you want to stay with. Attachment, as I described before, which is paired with caregiving, because for a person who's looking for attachment, he needs somebody else who's taking care of them. But the 2 on the top are more important for the patient's status with the patient's relationship with their clinician, because ranking, that is what you see when lions fight to get dominance over their pack, is the same thing that you have with a doctor or with a patient when the doctor says you have to say this, to do this because I said so. Because this is the best and I know what is the best. And you may have the same from the patient saying, no, I read online that this is better. No, but actually I have to explain, no, I know this is. I take my decision, you can't force me doing something I don't want to. And it's really risky because it's subtle. It's really hard to keep track in which system you are. And the one we're looking for is this one, cooperation, in which you pass from this to this. Doesn't mean that you have all the knowledge and competence that a doctor has, but you have some competence, you have some knowledge, which is as valuable as the doctor's. And so even if you have different elements to put to your care, you should join forces and bring all your pieces together to have the better care you can. So this is a famous image and scheme. It's like the road to patient empowerment. As you said, it has engagement, so it has to involve patients in the shared decision making, in the understanding, in the education, which means to understand diagnosis and treatment and their condition, obviously. Activation, because with those 2 alone, you won't go anywhere. A patient doesn't want to be committed, to be collaborative, won't help you. And those things are really important because they bring you to that white word over there, the expression, the shared decision making, which is so easy to misunderstand. It's not that the patient has to choose between option 1 and option 2, but together with the clinician, they have to understand all the things that are on the plate. Because apart from medical symptoms and numbers in charts and exam results, there are a lot of elements that only the patient can see. Only a patient may know in that moment in his life as an individual what are the consequences of his disease. If we, another story is that of a patient who were struggling with cancer and she was having a real aggressive therapy, and she decided to go on and keep fighting against cancer because she wanted to see her first grandchild. And so she said, no, I know it's painful, I know it's not worth it because she was like 92, something like that. And she said, I want to see my first grandchild. And who's the doctor to say that it's wrong? Every person has the right to make their own decision as long as they are aware of the implication of that. Thank you.